So I'm delighted to talk to you about ethics. There's a big overlap between ethics and palliative care. We say that ethics is really the question of what should we do, and then palliative care, depending on the situation, may be the practical application of then how you do that. So I'm hoping to leave some time at the end so we can have some discussion, ask questions. But I wanted to share a little bit about ethics consults here at Loma Linda. I thought that might be something that you might be interested in hearing about. So let's see if I can get this to work. Maybe not. What do you think? Oh, beautiful, thank you. So our objectives for today, we want to talk about some common ethical dilemmas arising at the end of life, explore the root causes of these dilemmas, and then describe ways of approaching and resolving some of these. And I want to take a minute and dedicate this talk to my mentor and friend, Bob Orr. Robert died last year, sadly, but I would not be doing ethics if it wasn't for Bob. I met him when I was a medical student and did some research with him. He was one of my mentors in my family medicine residency and just a delightful person. Bob said that when he first started doing ethics consults at the beginning of his career, the question more was a patient had a gangrenous leg. A surgeon would come to him and say, listen, I need to amputate this leg. I can save his life. I know it's the right thing to do. He's refusing. Can I just do it anyway? That was the majority of consults he got. Fast forward to today. Now it's kind of 180 degrees different. And often the consults we get are in our intensive care units, someone with multi-organ system failure who is clearly dying, and the family saying, can't you do one more round of chemo? Can't you do another surgery? Can't they get a liver transplant? So very different. So thank you to Bob for really teaching me everything I know about ethics. And Bob agreed with this statement that medicine is fundamentally a moral enterprise. Eric Cassell, in his book, The Nature of Suffering, stated this, and it is true. Really everything that we do, all the decisions that we make have at least some ethical undertones. I would argue that if you're a busy intensive care unit physician, you're taking care of 20, 30 patients in the ICU, deciding how much time you spend on each individual patient is an ethical question. It's really about allocation of scarce resources. And what is that scarce resource? You, as the physician, right? We often don't think of ourselves as scarce resources, but we certainly can be. So this is important to think about. And again, ethics asks the question of should we be doing certain things, whereas medicine says, boy, what can I do? What new surgical technique can I come up with? What new immunotherapy can I come up with? What new other intervention procedure can I do? If you think about back to the 1960s when dialysis was first invented, we had one dialysis machine. And the question was, who gets it? Who should it be for? And for those of you who know the story about dialysis, they came up with a euphemistically called the God Committee. This was a group that was supposed to decide who should get it. And so they looked at factors such as, well, let's see, this is a pastor or a police officer, or this is a teacher. So they're really fundamentally more worthy than, say, maybe someone who is unemployed, who is homeless. And so they used these type of criteria, which we cringe at today, and we say, oh, we would never use those criteria. But that's what they had to work with. So ethics is really about what should we do. One of the analogies that I have found helpful when I'm teaching my students about how to think about ethics, if you know the women's soccer team and you know Megan Rapinoe, she's kind of the star of the soccer team, and she just kind of blasts down the field and she dribbles and she shoots and she passes and she scores, and she's just amazing, and you can barely keep up with her, right? That's kind of how medicine is. Thinking of the latest, greatest, what can we do? What is the newest technology that we can go with? Ethics, on the other hand, is what I think of as a middle-aged, overweight father of three who goes out on the soccer field and tries to keep up and ends up having to take a break and say, hang on, I need to catch my breath. Can we just slow down for a second? So ethics is saying, let's pause, let's wait, and let's think about the implications of these decisions, right? So ethics, not quite as exciting to watch as medicine, but I would say really, really important. So why do we even have to think about ethics really today? And it's really because of our amazing technologies that we have. Things such as dialysis and ventilators and organ transplants, ECMO, immunotherapy. None of these are by themselves inherently good or bad. There's nothing positive or negative about any of them. The question is, does this therapy, is it going to help my patient meet their goals? And fundamentally, when we're looking at advanced illness and end-of-life care, the question for most of our patients is, what are you willing to go through? What are you willing to put up with to get more time? Because there's an extraordinary amount of things that we can do to get you more time. But the question is, are we getting you good time? And the only one who can tell me if that time is good or not is the patient or their surrogate, right? So nothing good or bad about these, but really, are they helping you achieve the goal that you are wanting to achieve? Most of you are familiar with these ethical principles. We talk often about beneficence and doing good for people. Clearly, we want to do more good than harm, or non-maleficence, which is avoiding the bad or the harm. Autonomy is respecting patient choice. And Dr. Orr always taught me that autonomy is really based in negative rights. So people can refuse anything and everything they want to, including that amputation for gangrene that might save their life, even if we think it's a really good idea. But patients can't, on the other hand, demand things that aren't appropriate or aren't indicated. But autonomy, I think, has gone far too afield in saying that people can demand anything and everything that they want. That was never really the goal of autonomy. And then finally, justice. This is one that we often don't think of when we're looking at individual ethics consults by the bedside, but this is certainly one that has become a lot more brought to the forefront in the last 2 years with the pandemic. Thinking about, how do we allocate scarce resources? How do we treat communities of people fairly? What is a good way to distribute the healthcare that is available? So that has certainly become something that we have become a lot more attuned to and aware of. So I want to bring your attention to the Lancet. They had a document just printed recently, their commission on the value of death. And they really look at death and dying across the world globally. And they talk about that dying in the 21st century is really a story of paradox. So depending on where you are, you will have a very different perspective on what the ethical issues are. In most high-income countries, such as the United States, most people would agree or say that many, many folks are overtreated at the end of life. Our intensive care units are full of folks who we know they're not going to get better. And how do we know that? Well, partly it's because we know they have advanced illnesses for which they've already been treated. Perhaps they have an advanced malignancy and they've exhausted all of their anti-cancer treatments, and now they're ending up in the ICU for sepsis or organ failure or respiratory failure from diffuse pulmonary metastasis. And we know we can't treat this. And yet the ICU is often the final common pathway. There are some countries that would say, you know what, I think that you are too sick to go to the ICU. Now think about that. That's not what we say here, but some countries would say, we know that we can't fix this and going to the ICU isn't going to make you any better, so why do that? But here it's often the final common pathway. Unfortunately, in low and middle income countries, many people are undertreated. They die from things that are really fairly easily preventable, and sometimes even without access to really basic pain relief. There are many countries in Africa where opiates are not available, and it's not necessarily a cost issue, but a legal issue. Just by law, they may not be available. So a great paradox in what we see and what people die from. I know this is a hard table to look at, but it kind of compares death and dying across the globe. The US is the second country here. It looks at overall life expectancy. So again, high income, middle income, and low income countries. In the US, right now, we're about 78, 79 years is average. If you look at Malawi, you're lucky if you make it to about 64 years old. If you look at the probability of dying between the ages of 15 to 60, the United States, we sit right at about 11. Again, down here in Malawi, it's 27. The under 5-year-old mortality, we're at about, per 1,000 live births, we're at about 7. Malawi is 52, so pretty stark disparities there. Deaths from communicable diseases, not really a matter here in the US and the UK, whereas if you look down at the low-income countries, much higher. But deaths from non-communicable. So you think of all the chronic diseases that people die from, complications from hypertension and diabetes leading to things like congestive heart failure, renal failure, much more significant. But they are increasing in low and middle income countries. So we are exporting that as well. So lots of disparities there to think about. And then this table that was adopted from Laughlin looks at kind of the changing nature of death and dying. And as you can see, if you look at before 1950, and this is 2019 and beyond, the level of technology was really quite low before the middle of the last century. Here it is now high and increasing. The detection of terminal disease was pretty poor in the past, quite high now. And it used to be really actually fairly easy to define death. It is much harder now. If you think about it, we all know about death after cessation of cardiac activity, but think of death from neurologic death or brain death is really a very modern concept and idea, one that did not exist before we had technology such as ventilators to keep the heart going, to keep the lungs inflating and oxygenating. So it's really much more complex. Death from chronic diseases was really non-existent in the past. Now it is the majority of things. Involvement in doctors in dying, that was really not a very familiar thing in the past. It was more something that you looked to churches and religious institutions, but now it has become very much a medicalized process. So lots of changes over time. Epicurus. Oh, thanks, excellent. Epicurus argues that death, the most frightening of bad things, is nothing to us. Since when we exist, death is not yet present, and when death is present, then we do not exist. The Lancet says that they have, they recommend 5 principles of what's called a realistic utopia. This is a term from John Rawls, who wanted to think about how to improve society. But they say the 5 principles are to look at the social determinants of death, dying, and grieving are tackled, that dying is understood to be a relational and spiritual process rather than simply a physiological event, which is often the way most of our hospitals look at it, that networks of care lead support for people dying, caring, and grieving, that it shouldn't be just doctors and nurses, but it really should be a community, that conversation and stories about everyday death, dying, and grief become common, and finally, that death is recognized as having value. That last thought is really, I think, interesting because in most of our societies today, death is something to be feared, it is something to be fought, it is something to be avoided at almost all cost, not just financially, but also at the cost sometimes of comfort, of dignity. And so can we as a society think of death as actually having some value? So let's take a look at ethics consults. So I did a review of our consults from 2021. There were a total of 149, which is actually an increasing amount. We used to hover at around 60 to 70 now. We've increased, and I don't know necessarily that COVID changed that. It's been on the increase. But these are kind of the general categories that we found. I'll show you in a graph that 1/3 of our consults were actually for people who are unrepresented. So these are patients who come in who they cannot talk to you, they lack decision-making capacity, and we cannot find any family or surrogate decision maker for them. That has been an increasing population that we've been seeing. Then we look at termination of pregnancy. Remember, Loma Linda does not do elective terminations. All of these consults were to make sure that we were following our policy that says that these are due to lethal anomalies, that these were due to women who were pregnant and then found that they had advanced cancer and needed to start treatment right away. So these are not anything to do with any elective procedures. And then potentially non-beneficial treatment. This is really the term that we use now or encourage to use instead of the futility word. Surrogate decision maker, small amount in the pediatrics world, and then some others. So here they are by distribution. So you can see this large light blue box is a third of all of our consults were for P23, and I'll explain what that is. That is our distribution. Now, some of these overlap because if we're talking about an unrepresented patient, maybe the question is, are we doing non-beneficial treatment or not? So there is some overlap, but these were the general categories. So let's look at a case. And these are composites. So they're not actual people, but they're very, very common themes that we see. Ms. Sanchez is a 34-year-old woman. She is unhoused. She has a known diagnosis of schizophrenia. She was unfortunately hit by a car while she was riding her bike and has suffered very significant head trauma. She underwent a hemicraniectomy emergently. Unfortunately, we have not been able to find any family. And now we are 2 weeks later and she is not weaning from the ventilator. And we think, her healthcare team thinks, that she needs a peg and trach. So how do we do this? How do we make this decision when she can't sign a consent? She has no family to sign a consent. What is the best mode of action? And let's contrast that with this patient, Mr. Larson. He's a 78-year-old man with hypertension, hyperlipidemia, COPD. He's on some oxygen. He's had coronary artery disease and underwent a CABG. He's had a prior stroke and he has some early dementia. He's been living at a skilled nursing facility for the past few years. He has no family on file. They had someone early on, but they have since died themselves. So the skilled nursing facility has no contacts. He suffered a cardiac arrest while at his nursing facility. He was coded for about 20 minutes and brought to the emergency department where he arrested again. And 1 week later, he now remains unresponsive. He is not breathing over the vent. Fairly stable hemodynamically. He's not on any pressors, and he has some brainstem reflexes. So a number of years ago, we thought we need a way of helping to make medical decisions for patients like this. The courts are what we would say is a last resort. They are not an efficient means of making decisions. So our policy numbered P23 was based on the California Healthcare Association, the California Hospital Association's policy of helping making decisions for people in skilled nursing facilities. So for a number of years, these nursing facilities have said, listen, we have these patients in our facilities that have no family. We need to have a process for how to make decisions for them. So they came up with this policy and we modeled ours very much along theirs. So the policy is really to provide a process for making ethically and medically appropriate decisions on behalf of persons who lack healthcare decision-making capacity and for whom there is no surrogate decision maker designated in an advance directive or a post form or via declaration that they actually said who they wanted making their decisions while hospitalized when they were still determined to have decision-making capacity. So when we think about making decisions, when we think about consent, I think we often think about the paper, the thing that the patient has to sign. But consent is obviously much more than that. And when someone comes into the hospital with, say, an acute pneumonia, and we want to admit them, we say, we would like to admit you to the hospital, and we're going to start an IV, and we're going to give you some fluids, and we're going to start some IV antibiotics. How does that sound? And if they say, that sounds great, let's do that, we don't actually have them sign something specifically for those interventions. So it is more of implied consent. But when we're doing specific procedures, such as perhaps diagnostic procedures like a lumbar puncture, or perhaps they need to undergo an MRI under general anesthesia, or perhaps they need a tracheostomy or a PEG tube placement, or they need some other surgical intervention, that's usually when we get an actual signed consent from them. So if they're not able to do that and they have no family, how do we go about that process? So consent is really not just a signature. It's about talking about the benefits versus burdens of these interventions. And so how do we apply that process when the patient can't participate? So our policy says that who makes this decision is a multidisciplinary team. I have often asked if we can do a 2-physician consent. That is it really an urban legend? It doesn't exist. There is no law that talks about 2-physician consents. Now, I believe places like the VA might actually have a policy that talks about that. And I think most physicians feel better to have someone else agreeing with them. It's always more fun to get in trouble with somebody else and not just yourself. But there is really nothing legally, a legal standard based on a 2-physician consent. So either you do things emergently. So if someone comes into the emergency department and they're exsanguinating after a big accident, there's no one around, you can't talk to them, you give them blood and you just do it. But if it's not an emergency, then again, it's this issue of this process of consent. So the team is a team that is involved in taking care of the patient. It's their physicians, their nurses, social workers, case managers, ethicists. We have a community representative on our ethics committee. And then if there are friends or neighbors or caregivers who know this patient, and they may not have legal authority, but they may have moral authority, we invite them to help us understand who this patient is and get some more background information. So how do we determine appropriate goals? Well, clearly, if we know that the patient had previously expressed wishes, we want to know that. We want to gain insight into that. I had a case not long ago that a patient had been at a board and care for a number of years. He had no family, he had not made any advance directive. One of the stories that the owner of the board and care had told us was that this was a man who was very private, didn't really talk about anything. He liked to work out in their garden. But one time he had to go to the pharmacy to pick up a prescription. And because he had to pay a $2 copay, he said, that's not worth it. I'm not getting that medication. That at least gives you insight into who this person is, what they value, what might be important to them. It may not tell you everything you need to know, but at least gives you some sense of what has been their priority. We also talk about relief of pain and suffering. How well are we able to do that based in their current situation? Can we preserve or improve their function, not just physical, but also cognitive function? What is the quality and extent of life sustained? And what's the degree of intrusiveness, the risk of discomfort of the treatment? And do we know anything about their religious or cultural beliefs that maybe a friend or caregiver might share with us? So then we try to apply the best interest standard. Again, in medicine, when patients can tell us what they want, that's honoring their autonomy, and we go with that. If they can't tell us, but their family member can say, you know, I know mom, we talked about this, this is what she would want. That's what we call substituted judgment. But then when there's no one, we use the best interest standard, which sounds pretty straightforward, but is really quite complex and very subjective. But in determining the best interest of the patient, it is not required that life support be continued in all circumstances, where treatment is otherwise judged non-beneficial or is medically ineffective or contrary to generally accepted healthcare standards, when the patient is terminally ill and suffering, or where there is no reasonable expectation of the recovery of cognitive function. So with that in mind, our committee makes decisions about doing procedures and sometimes actually stopping interventions. So I wanted to know, because I've been involved in a lot of these P23 meetings, how they kind of looked number-wise. So there were 55 consults for this specific request of unrepresented people. 27 of them were specifically for procedures, such as a surgical intervention, maybe, like I mentioned, a lumbar puncture, an exam under anesthesia, where typically we would get someone's consent. 12 of those were specifically for pegs and trachs. 18 were simply for, is it okay to transfer them to a nursing facility, either back to where they were, or this is now a new place where they would need to go. 10 were for do not attempt resuscitation orders. 4 were withdrawal of life-sustaining treatments, and 2 were specifically for transfer out on hospice. 4 of our patients had 2 separate meetings. 1 had 3. And actually, 2 patients had 4 different meetings because they just needed multiple surgical interventions. So again, how do we determine their goals? So let's think about this when we think about our patient, Ms. Sanchez. So this is our young patient who has now been hit by a car. She has had traumatic brain injury. She underwent a hemicranectomy, which was emergent. And now she's relatively stable. She is starting to make some purposeful movements, intermittently seems to have some attention and follow some commands, but not very consistently. And now we have to say, should we place a peg and trach? Because she's not able to wean off the vent. We think actually that she could, but her attention just hasn't been consistent. We think that if she gets a trach, she actually probably won't need the ventilator at all and will be able to protect her airway that way. So we think about these things. So do we know what her previously expressed wishes were? We don't, because we don't have any family or caregivers. Pain and suffering, she has had some pain, we think, from injuries, from post-op, but we've been managing that. What about the preservation or improvement of function? We know that with traumatic brain injuries, people can improve for up to a year later. So there is certainly the hope that she can continue to improve. I don't know if she'll get back to being independent, but we hope so. Cognitively, she may continue to make strides and be able to interact and talk and maybe even get to the point where she can make her own decisions. What is the quality and extent of life sustained? Again, quality of life is hard to judge for others, but we think she has the potential to improve. What is the intrusiveness, risk, or discomfort of treatments? When you think about all the interventions we do, pegs and trachs are fairly on the minimal scale. It's a minor surgical intervention. It is easily reversible. If you don't need the trach anymore, you get decannulated. If you're able to eat on your own, you can have the peg tube removed. And unfortunately, we didn't know really any cultural or religious beliefs. So the committee talked about Ms. Sanchez and said, you know what, we think it is reasonable. We think it would be in her best interest to undergo a peg and trach and then go to a facility to continue her rehab. And that's indeed what happened with her. But is it different for Mr. Larson? He's our gentleman who came in after an arrest, fairly significant arrest, long amount of time without oxygen to the brain. And our neurologists have said he's got significant hypoxic brain injury, and we do not think he really has any significant chance of improving, of waking up, of being able to interact with his environment. So again, we ask the same questions, right? Do we know his previously expressed wishes? He came from a SNF where his caregiver said, you know, he was a very easy to get along with, happy-go-lucky gentleman. He was essentially bedbound, but he was able to eat on his own. He had hemiparesis from his prior stroke, but he had made comments because he had previously family members that had died in ICUs on machines. He had said, you know, if it's my time, I don't want to be on those machines. Don't do that to me. But he never documented that. He never wrote it down, but they remember these conversations. Relief of pain and suffering. If he has significant brain injury, it's hard to know if he's having a lot of pain, but we watch for that. We watch for the nonverbal cues. What about his improvement of either physical or cognitive function? Seemed like it was pretty minimal, not likely to really be the person he was and be able to interact with his environment. In surveys of Americans, when asked, would you want to be maintained in a persistent vegetative state? The majority of Americans say, no, I don't want that. We're very willing to go through a lot of interventions if we can get better and get back home and get back to the lives that we were living, even if it's in a diminished state. But to not ever be able to be aware of your environment, interact with family members, most people say, I don't think I'd like that. There are some who may say that's acceptable. So when we're thinking about best interest, we're thinking about what would a reasonable average person think. Cultural or religious beliefs, he was Christian. They knew that. They knew that prayer was important to him, but didn't know any further details. So after our multidisciplinary committee met with the caregivers from his facility, we talked about the benefits versus burdens of continuing ongoing ventilator support. and sending him to what would probably need to be a different facility, a higher level of a facility, because the place he came from could not do ventilator support. It was decided that in his best interest, we would withdraw life-sustaining measures and keep him as comfortable as possible. And he went on to die in our hospital. So two very different cases where you have to think about, how do we best serve this person? How do we think about their best interest? Atul Gawande says you may not control life circumstances, but getting to be the author of your life means getting to control what you do with them. So those were a couple of cases of what we call our P23 meetings. But now let me share a case about really different values. So some of the other categories of decisions that we have to think about are, does this patient have decision-making capacity? If not, who is their surrogate decision maker? And what's the most appropriate course of action? So this was a man, 62-year-old with ALS, or Lou Gehrig's disease. He had been ventilator dependent for the last couple of years and had been in a nursing facility and had seemed content with his quality of life at that time. Unfortunately, he got admitted for sepsis because he had developed a large sacral wound that started to get worse and worse over time. His nutritional status wasn't great. He had to be turned frequently, and it was just really hard to manage this wound. He then developed renal failure and was requiring hemodialysis. And when he came in, he couldn't communicate. Prior, he was able to blink his eyes and make some eye movements that the family was able to interpret and help us understand. But when he came in acutely ill, he was not able to even do that. So part of the team's question was, does he have decision-making capacity? Once his sepsis was treated and it resolved, he woke up enough that he could at least intermittently make some eye movements and eye blinking. And the team at that time thought with the son's help that the patient had indicated that, yes, I want to continue with current treatments. The wife and daughter felt differently. The wife and daughter felt like he was suffering now and said we should really focus our efforts on keeping him comfortable. So he at least had intermittent decision-making capacity, but that waxed and waned. So if he lost that capacity, who would then make his decisions? He hadn't appointed someone. He hadn't told us who he would want making those decisions if he couldn't. And the wife and daughter were on one side and the son was on the other side, both parties feeling like they were advocating for what was best for him and saying what he would want himself. So that often leads to challenges. Unfortunately, he continued to have intermittent infections and other complications, but he was able to get out of the ICU. He was off the ventilator at this point in time. He was just on a trach mask, continuing on dialysis. They'd asked surgeons to see if they could debride this wound, to do a flap, anything that could help. The surgeons did not think that that would be a feasible intervention. So when I got asked to do this consult, the question from the attending physician was, what should we do? The surgeons say that surgery is futile. And so shouldn't we stop dialysis because isn't it all of this futile? And so my reply was that even though some interventions may not be recommended or feasible, such as surgery, he was actually tolerating dialysis quite well. He wasn't getting hypotensive. Dialysis was doing what it was supposed to do, right? Filtering the blood, it was accomplishing that. Was it accomplishing other things like getting him better overall? Probably not. So in my consult, I recommended that the things that were truly physiologically doing what they were supposed to do should be continued, if that's what the family requested. But there should be a discussion about what should be limited, if anything. Should we say that if they do get hypotensive again, if they do get septic again, that we won't go back to the ICU? So there's this, we have used the term futility for many, many years. In ethics, we're trying to move away from that because it's very hard to define. Ethicists back in the 90s tried to define it, and some recommended that we say, if it hasn't worked in the last 99 out of 100 cases, it's futile. But people said, oh, 1%, it worked? That's great, we'll take it. So numerically, it's hard to define, right? But so we talk about physiologic futility, which is fairly rare. So this we saw sometimes in our COVID surges when someone was in our ICU, had bad COVID pneumonia with ARDS, was on a ventilator, and the ventilator was at 100% FiO2. They were on INO, and they were still only sitting in the 70s and continuing to decline. That I would say now the ventilator is not actually accomplishing what we were hoping it would accomplish. Versus qualitative futility, which is, yes, the ventilator can keep you oxygenated and ventilating, but is it helping you improve your cognitive function? Is it reversing your ALS? Is it getting your cancer better? Doesn't do those things. So we distinguish between physiologic futility and qualitative. Most of the consults we get are really for this idea of qualitative futility. So I'm gonna show you a clip here in the minutes before I move to questions and answers. This was a documentary done on PBS called Money in Medicine. I think that the access that it had to patients and families was really quite extraordinary. So here you're gonna see, this is a patient at UCLA in their ICU. You're gonna hear the perspective of the son, and then you're gonna hear the perspective of the physicians, and how very different those perspectives are. So let's go ahead and take a look at that.
Miss Stoneham, how are you? Miss Stoneham, can you see me? Are you in pain?
I don't know what's going on inside the mind. She's nonverbal,
Miss Stoneham.
but she's able to respond to pain and noise and stuff like that.
This has been a long journey for you.
Yes, it is.
That began with her stroke, that required a breathing machine, feeding tube, and dialysis.
I feel like my mom is my baby, so to speak. And so I want to nurture and care for her in any way that I can. If there's something that can sustain her medically, she would want that.
If the nurses were doing the rounds and such, and they found that her heart had stopped, at that point, would you want us to try to do something to try to restart her heart?
One of the things that she would want is every opportunity to live and to enjoy life. As I look at how she's doing now, I'm glad that I didn't make the decision to let nature take its course. You know, miracles happen if you believe in miracles.
We do run out of miracles, and there is a time for everyone.
I don't know what that time frame would be that I feel or some family member feels, she's really not here with us now. I suppose something like that, something spiritual.
This is not something that I would want. It would be torturing me. On the other hand, other people feel very differently.
Giving you some medication.
You do everything you can to preserve life. That's what my mother would want. Okay, let's find your favorite picture again. She likes to be talked to while looking at the photographs. This is your first baby, way back in the times. Okay, here's your favorite picture. This is when you were very young. Always very glamorous, huh?
What hasn't happened in the past 10 months is she hasn't left the hospital. In the meantime, basically our hospital has become her home.
UCLA, through their ethics committee, put in place a do not resuscitate order, which, as her durable power of attorney, I am against, and I believe my mother would be against.
Okay.
If she gets any new infections, for example, they will not treat them. In other words, they will not do heroic efforts to save her life.
Yes, oh good, you nod your head.
Fortunately, they will not terminate dialysis
You see my head?
or the ventilator,
Yes.
and instead they're going to not escalate her care.
If a patient is very unlikely to survive, but the physicians feel that there's some chance by using all the available resources, they might be able to pull them through. They appropriately will use all of those treatments. Yet they may recognize that a further deterioration would mean that that goal is unattainable. And under those circumstances, it would be inappropriate for them to further escalate care.
Yes, you're doing good. Hang in there. Every day is a miracle. Why all of a sudden am I not in a position to make decisions about her life-ending choices?
I think there's a disconnect between what we can do and what we can do that helps.
I'm gonna visit you back again later.
We're in a situation where we have very powerful technology, medications, and tools and expertise in caring for people in critical illness. But I think we've approached a point where we're almost abusing that power.
It's under those extremely unusual circumstances where the goals of medicine are being tested by the use of technology that physicians need to begin to pull back, have intensive conversations with families, and sometimes consider overriding them.
Essentially, they're pulling the plug. I call it a medical execution. It is essentially a death panel.
It's difficult when we are put in an adversarial position where we have to tell patients' families that I don't think this will help. This is exacerbated by discussions in the general media and in politics, unfortunately, with statements like death panels and really politicizing a deeply personal issue.
It is euthanasia, and I feel that the decision was made because she basically wouldn't go away.
We do not practice euthanasia under any circumstances. Euthanasia is the active promotion of death with that intent.
I'm gonna suction you again, okay?
We use machines to be able to protect patients from dying from an underlying condition.
Just a little bit.
And it's possible to use these advanced tools that we have to not help patients, but to actually prolong a death or to actually produce more suffering or less comfort. And under those circumstances, physicians may very well say no.
We have to be able to save lives, perform miracles, and we also need to figure out the best way to allow people to pass with dignity. But that's a discussion that really doesn't take place when you show up to our emergency room in extremis. That discussion has to take place with a trusted primary care provider that's been your family doc for years, ideally. Because when you come to us with multi-organ failure, we do what we know how to do. And America has not focused on that particular discussion in advance enough. And we're not talking about death squads, we're talking about having real discussions about the end of your life and how do you want it to be.
We have to start being able to talk about it. And not just because we're spending a huge amount of money on it, but because a medicalized death is not what most people want.
So hopefully this will generate some discussion. I cringe kind of every time I watch this. One of the things I think I found most disturbing from a faith-based institution, early on in the conversation when the physician was talking with the son, and the son talked about miracles, and the physician said, well, we run out of miracles. I don't know that that's true. I don't know that God has a quota on miracles. And I just don't know how helpful that would be to say that. I don't think it'd be helpful. My question for him would have been something more like, what would a miracle look like to you? And really engage in a conversation and a discussion. It has, I think the other thing that this illustrates is the son's perspective. So he said very clearly that they were going to continue the vent, dialysis, everything she was on. They weren't going to escalate. That was true. But then he said, and that is a medical execution, that is euthanasia, which clearly from a medical, ethical, and legal standpoint is not. They're not equivalent. And yet that is his underlying heartfelt belief. It's kind of like when I have patients who say, you know, I've been on dialysis a long time, I hate it, I really want to stop, but if I do that, that would be committing suicide. Well, we know medically, ethically, legally, that's not true. But if they feel that, that's a very different thing. And it doesn't matter how many lectures I give them or articles I give them, that probably won't change how they feel about that. So you really have to address the underlying feelings and not just facts. Because I think often we're kind of at this standoff where we're talking about facts, families talking about feelings, and we never quite meet. And the family won't just all of a sudden start tuning into our facts. So what we have to do is we actually have to change and acknowledge those feelings and really go to that plane and see if we can make some breakthroughs. So what to do? And again, this is a problem for high-income countries, right? ICUs with ventilators, dialysis, probably not available in many low-income countries. And so the questions are different, but what could we do here? Certainly we can encourage conversations. Just starting to talk about these things is really helpful. Many of our patients and families don't even want to think about these things or talk about them with their family. Sometimes the patient really wants to talk about it. I saw a lady in the cancer center yesterday who really wanted to talk about a plan for if her cancer got worse, but her family would shut her down and say, no, mom, everything's going to be okay. We don't need to talk about that. Well, she probably does need to talk about that, but her family isn't letting her. So encouraging conversations is really helpful. Think about what's important to you. Again, what are you willing to go through? What are you willing to put up with to get more time? Because that's really the question. There's almost a limitless number of interventions that we can do, but will they meet your needs? Are you willing to go through that? Appoint an agent. Even if you don't have all the answers about things you would want, at least appoint someone who you know and trust would hopefully make decisions that you would be okay with. Completing an advance directive can be helpful, not always, but particularly if there's family conflict. You know, if you come from a family of 7 people who all show up at your bedside and they all agree and say the same thing and there's no conflict, you don't even need an advance directive. But when there are differences of opinion among those family members, that's when a document can be very, very helpful. And then finally, I would say live well. We have found that people who kind of live chaotic lives, burned bridges, lost relationships, that often carries over into the end of their life. And those who have lived well, who have loved those around them and been loved, often things go much better. We know a survey from the California Healthcare Foundation asked, what do you want if you were really sick and getting near the end of your life? And the things they wanted are to share memories, to pass on wisdom, keepsakes, settle relationships, establish legacies, make peace with God, and to ensure that those who are left behind will be okay. And that's so, so important. And sometimes we spend a lot of time on doing other things instead of these. So endings matter. Again, Atul Gawande says in stories, endings matter. Endings are not entirely controllable, but we are not helpless either. The chance to shape one's story is essential to sustaining the meaning in life. So with that, I'm going to pause and see if there are questions, comments, concerns.
So we have a few moments for questions, and I have a second mic if we have several hands on different sides. Got one on each side. Do you mind taking one on that side? Thanks.
I have a quick question. Dr. Mohr, thank you for that presentation, by the way. Do you feel that in a faith-based institution like Loma Linda, that facts and feelings chasm is easier to close? And I'm just thinking, this gentleman who shared, he mentioned multiple times like faith and miracles, and whether even getting a religious faith-based leader or maybe a pastor of the patient's church would have been useful. And I don't know if that's ever integrated either at places like UCLA or even here.
That's a great question. So thank you for that. I think religious beliefs and spirituality are very, very important. Getting someone from their own faith base may or may not be helpful. Sometimes those religious beliefs are very similar and they will say the same thing. Listen, you just need to keep going. Miracles happen and we're just going to rely on God. So it depends. It very much depends. Here at Loma Linda, we're fortunate to have wonderful, wonderful chaplains. We could use more, but I think we certainly pay attention to a lot of those faith-based questions because again, as we're trying to talk about, dying isn't just a physiologic event, right? It's a spiritual event, it's a communal, a social event, and I don't think we pay enough attention to that. I think that acknowledging his concern about anticipatory grief of losing his mom and really exploring, tell me more about your mom, tell me more about her faith and what that has been like, I think opens up a dialogue. Doesn't always solve things, but I think that having that dialogue is really, really critical. Now, as the video showed, so here's someone who's been in a hospital for 10 months. Again, we can debate about whether that's a good use of medicine or not, but that commonly happens in intensive care units around the country. And the question is, societally, how do we change that? Because I think it's much broader than one patient at a time. Question over this side?
Yes, I was just wondering if the patient with a Loma Linda or you're consulting, would they consider like LTAC or something like that?
A patient considering LTAC?
Yeah, for that patient in the video.
Oh, yeah, I don't know why they might not be a candidate for an LTAC. I don't know if their needs were above what an LTAC might take. So for those of you who aren't familiar, LTAC stands for long-term acute care hospital. So we keep kind of coming up with more and more places. So you have a hospital and then you have an LTAC, which can do basically ICU type care. They're not doing a lot of major surgeries, but they can keep people who are on pressors, on ventilators. So I'm not sure if that had come up or not. Question here. Or there.
In that, okay, go ahead. Okay, in that example, it seems the 10 months of treatment were for the son rather than for the mother. In real life now, if you were to talk about the ethics of cost, how would you introduce that to someone like the son?
So that's a great question. So I will tell you this. When we do individual ethics consults, if I was consulting on that patient, I would not talk about cost. I would talk about, tell me about your mom, who is she, what's important to her, how would she feel about this? And I have to rely on him. If he says, my mom would want this, she said, keep me alive no matter what, I have no choice but to believe that he's authentically representing her wishes. But on a larger scale, right, on a societal scale, we do have to talk about cost. If this patient, say, is Medicare, or some of our other patients who are Medicaid funded. Medicare and Medicaid are the systems, our collective taxes contribute to those systems to support people. And the question is, do we as a society, is this a good use of those funds? Should they be going to other things? Vaccinating children, getting more counselors, therapists in schools for kids, you name it. That's a debate that's really hard to have because it's hard to have our politicians have that debate. And so collectively, it's hard for us without then talking about things like exactly he said about pulling the plug and talking about death panels. So it's a hard conversation to have. We'll go here and then here.
Thank you very much for your discussion. It seems to me a lot of times the conversation about these things gets delayed to way late in the course of events. And how do we as practitioners move that forward? It seems to me even some of the terms we use for people, palliative care, comfort care, end of life care, so people are resistant even to ask for those kind of resources just because it feels like they're giving up. It seems like we need to move things forward to some kind of a total life care, get the conversation going early on.
No, you're absolutely right. It's interesting because the palliative care, I spent a great deal of my time actually explaining to people what it is and because they often have misconceptions about what it is. I think I'd like to change our team name to the Quality of Life team because that's really what we're about. How can I help you feel as good as possible for as long as possible with whatever interventions you want? Whether you want to be on a vent and dialysis, whether you want to go home and be comfortable, it's not really a matter to me as long as you feel good and you are getting good time with family. But moving these things up, again, it comes down to how do we change the way society views death? Can we talk about it in a way that makes it less frightening for people? And that's, I think, a good place for our churches as well.
One more question here.
I have seen families who bring grandma in and say, do everything. And you question them a little bit and find out a little bit more about it. And you found out that they've neglected grandma rather badly for quite some time. And they're on a terrible guilt trip. Yeah. Is this gentleman on a guilt trip? How can we find that out and help him with that sort of thing?
That's a great question. You know, certainly we do find family members. It's often the daughter. So, and it's usually women. So the last statistic I heard was that you need 4 daughters or 4 daughters-in-law in order to have a 50% chance of staying in your home as you age. So get busy with that, right? But it is usually daughters. There are great sons out there. I don't want to take that away. Wonderful sons out there, but it's usually women who do the caregiving of elderly parents. And usually it's the daughter who's been taking care of dad for years that says, you know what, dad's really been suffering. It's time to let him go. And the daughter from New York who flies in who says, we got to do all this stuff. And she hasn't seen dad in 2 years. So again, we need to address her grief and her distress and maybe her guilt, because otherwise it's going to be a very messy situation. But, you know, in my younger, more naive days, I used to think that if I said the right thing, we could have the family come together, they would all hold hands, sing Kumbaya, and everyone would make amends, and it would be a beautiful, like, Disney movie ending. What I've realized is that families come with all this baggage from decades, right, of living together, of fighting together, and that if that is how they've kind of lived their life, I'm probably not going to change that in the last 3 days of their life. So we do try to enhance communication. We try to help people at least see each other's viewpoint, even if they don't agree, and try to come to consensus, but that doesn't always work. But again, acknowledging people's feelings, acknowledging whatever it might be, grief, anger, guilt, fear, is really, really important, because then they're often able to express what's really going on behind some of these decisions. So thank you all for your time, and I hope you enjoy the rest of APC. Thank you.
Can you see why this is one of our favorite teachers at Loma Linda for students and residents?